Hello friends, this is Dr. Sourabh Patwardhan from Nandadip Eye Hospital PG Institute and FECO Training Center, and in this video I'll be speaking about a recent case of mine where we had a posterior capsular rent. I wanted to know when it happened, why, and how it really happened. So this is when I noticed it. What you can see here is there is a vertical rupture of the posterior capsule, and it was noticed when I took out the last cortical plate which was there. But when did it really occur? So we have to review the surgical video. When you have any complication, it's must that we must review the surgical video, because there are many things which go unnoticed when you are actually operating. So this is a 50-year-old gentleman with intumescent cataract, as you can see, and I already stained the capsule, used a heavy OVD, combination of hyaluronate and chondroitin, and I am using my standard technique of intralenticular aspiration using 27 gauge cannula. But as you can see here that the cortex is not that liquefied, so I could just remove little bit of it. These are the cases where there is a higher risk of capsulorhexis going out. This is the next stage where I milk out the fluid. I call it peripheral stroking. So you use the heavy OVD from periphery to center and try to flatten the anterior capsule and remove those fluid pockets under the capsule. So I started the capsulorhexis now using the bent cystitome, and here it started becoming smaller. So I then used a microcapsulorhexis forceps and took out the capsule from another radial tear which I had created initially, and I could complete the capsulorhexis from one side, but it was still smaller. So I created a small nick using vanas, and then I started enlarging it from the other side. Here it hit a fluid pocket, so trying to go out, but I could easily bring it back in. So now the plan is to do primary chops. This is a mature cataract, but it's not that hard, so it's around grade 3. I want to do the primary chops, so I'm using a longer Sinski here, 1.5 millimeter Sinski, and I'm using bursts of longitudinal phaco to bury my phaco tip in, and then using the long Sinski to break the nucleus into half, and then I will further chop the nucleus into small pieces. All is going well at this point. I am using all the technically correct maneuvers, not going into periphery anytime, using the right amount of phaco power, burying and then dividing the nucleus into small pieces. Once all the pieces are divided, I will go ahead with the quadrant removal here, and that is also going on fine. I am trying to keep my phaco tip right at the center. Endothelium is well protected by the chondroitin hyaluronate combination, and the pieces are getting emulsified very nicely here. So half nucleus is over, so I am going to rotate the second half in front of the phaco tip, and now I am going to emulsify the second last piece here, staying in the center, and now the last piece, and here I tried to divide it, and you can see here this is the exact point when the rupture occurred. You can see the linear opening there on the posterior capsule, and in slow motion you can see the moment I tried to chop the last piece, the tip of the Sinski touched the posterior capsule, and the posterior capsule was already bulging, because you can see the plane of the piece was not that deep, it was at the iris plane, but the posterior capsule was already coming up. At this point when I was operating, I didn't notice that, and I continued doing phaco, and you can see the followability is quite good at this point also. So there was nothing to tell me about the posterior capsular rupture, but this is the moment of realization when I could easily see the vertical opening of the posterior capsule. So this is the time when you observe, you plan, and then you execute it. So the first plan is to inject 2% HPMC from the side port, so that there is no collapse of the anterior chamber and there is no vitreous prolapse. I observe that there is no nucleus piece left, so only thing which is left is little bit of cortex, which I have to remove. And when I injected OVD, you can see that it was not entering the vitreous cavity, which indicated that the anterior hyaloid is in fact intact. That's why there was no vitreous prolapse, which is a good thing, because if anterior hyaloid is intact, we don't need to do anti-vitrectomy. And I was just checking for the anterior hyaloid just to make sure I could touch the posterior capsule, and there was centrally anterior hyaloid which was present, and there were no vitreous strands there. Now for the remaining cortex, which is there in only a couple of quadrants, I am using dry aspiration. So I am using the aspiration cannula of the bimanual, and under visco itself, without any irrigation, I am carefully aspirating out the cortex. So here I am just catching hold of the cortex and then pulling it out, just like how we do with Simcoe aspiration cannula, and I am not trying to aspirate it inside. If I try to aspirate it inside, the AC will collapse and you will have maybe anterior hyaloid rupture. Once the cortex is clear, I am going to place 3-piece hydrophobic IOL in the sulcus. Now usually I first place it in the anterior chamber, because if you try to put it in the sulcus right in one go, many times the haptics may enter into the vitreous cavity, and then it is quite tough to bring it back, and also you might rupture the anterior hyaloid. So first step is to just place the 3-piece IOL in the anterior chamber, and now the trailing haptic has to be first placed in the sulcus. If you try to push the leading haptic, it's always difficult, so it's better always to push the trailing haptic into the sulcus. While pushing it, see to it that it goes in touching the iris tissue here, as you can see here, which means that you are exactly pushing the haptic into the sulcus. If you try to push it too deeper, it might enter the back, which we don't want in this case. And now once one haptic is in the sulcus, again the second haptic is rotated in the same manner into the sulcus. Now this patient, I am operating on topical anesthesia, but the patient is very cooperative, otherwise I would have given a posterior subtenon block. Now once the IOL is in the sulcus, I am doing optic capture here. As you can see, the CCC is central and small, so I could achieve the optic capture here. Optic capture helps in again creating 2 separate chambers. So now the vitreous cavity is well divided from the anterior cavity, which will help in future, so there is less chance of inflammation in the posterior segment. Now I am doing the OVD removal, but I am using very low bottle height of around 60 centimeters, so that I don't want further hydration or further fluid getting pushed through the posterior capsular opening. Otherwise it may start increasing the vitreous pressure, and then vitreous may prolapse. So I don't want that, so it is better to aspirate out at low bottle height, or you can just do passive wash of the anterior chamber, which can also take care of the remaining OVD. Now there is some OVD which is trapped behind the IOL, so I have to give anti-glaucoma medications. Now I always use diluted triamcinolone, though I am sure here that there is no vitreous and I have already achieved optic capture, but this diluted triamcinolone will help in checking if there are any vitreous strands which are remaining. After this I will push little bit of diluted pilocarpine so that the iris constricts and the IOL also stays very safely in the optic capture position. So this is the end of the procedure. I am quite satisfied with the outcome. This patient I had planned toric IOL, but the cylinder was very small, so instead I just enlarged the incision on the steep axis, and that will take care of the remaining astigmatism. So why in this case the rupture occurred? So this is my hypothesis. So this is the last piece which is there, and there is already fluid deviation. There is a fluid accumulated in the Berger space during the procedure, and this happens in some cases. And now I am trying to chop the last piece where the Sinski, though it is blunt, it touched the posterior capsule which was undulating because of the fluid deviation, and then it caused the rupture. And because it was already separated from the anterior hyaloid, in this case the anterior hyaloid was intact and untouched. I think anterior hyaloid separation or the fluid deviation is one of the major causes for last piece rent, like you saw in this particular event. For more such videos and phaco training, you can contact me. My contact number is there in the description, and do visit our website. Thank you.